The rotator cuff is a group of four muscles that work together to stabilize and move the shoulder joint, making it essential for almost every upper body movement. These muscles have each distinct roles, and understanding them is key to providing effective treatment. The supraspinatus sits on top of the scapula, and it's responsible for initiating arm abduction, or lifting the arm out to the side. The infraspinatus, located just below the supraspinatus, controls external rotation of the shoulder and stabilizes the back of the joint. The teres minor assists the infraspinatus with external rotation and further refines shoulder stability. Lastly, subscapularis, found in front of the scapula. It's responsible for internal rotation and plays a crucial role in anchoring the humeral head securely into the shoulder socket. Let's move into techniques specifically designed to address these vital muscles and improve overall shoulder function. Once you've completed a proper warming phase, let's dive into our first technique. Start by locating the rear deltoid. This will be your landmark. From here, you want to find the insertions of the rotator cuff muscles, which are located just behind the rear deltoid. Now, cradle the arm with both hands for support and stability. This allows you to maintain control as you anchor your thumbs into the rotator cuff insertions. As you do this, think of gently moving the rear deltoid out of the way, so you can better access the rotator cuff. Use your thumb tips to apply more focused, acute pressure in tight spots, and use the pads of your thumbs for broader, more even pressure. Cradling the arm is key here. Not only does this provide stability, but also allows you to incorporate some better scapular and arm movement into the technique. This keeps the work dynamic and enhances your ability to release tension more effectively. The movement of the scapula and arm makes the technique feel smoother and more fluid. If you got smaller hands and you're working on a bodybuilder, no big deal. Just create an M shape with both your hands and peel the rear deltoid back like you're peeling a potato. Then drive into those insertions like a torpedo, zeroing in on the target. Strong, productive thumb circles here, just like before. It's not as elegant, but hey, there's no one-size-fits-all approach to massage. Before we dive into any active release techniques, let's take a moment to explore some gentle mobility of the rotator cuff. Start with a low impact approach by rolling the humerus forward and backwards in the socket. This is a great way to ensure your patient is relaxed and comfortable. Take this opportunity to inform your patient that the mobility drill will be passive, so they should completely relax. Tell them to play dead and let you do all the work. Start by placing your hand at the crease of the patient's elbow. This provides a stable fulcrum to effectively mobilize the shoulder. With your other hand, gently grip the palm or wrist to guide the movement. Begin by slowly rotating the shoulder externally and internally, keeping the range of motion small, about 10 to 15 degrees to start. Gradually increase the movement as the tissue allows. If your patient's forearm reaches parallel to the ground during the rotation, and only if it does, you can advance the technique by pushing your fulcrum hand to gently guide the elbow into scapular depression. Once the shoulder is in this position, continue with more internal and external rotations, moving with precision and control. If your patient has poor range of motion, do not upgrade this version of the technique. Stay in the basic movements to ensure safety and effectiveness. This technique is incredibly rewarding when appropriate and often leaves patients impressed. It's a great way to incorporate a unique range of motion drill into your treatments, making your session stand out while providing real value to your patient. Keep your patient in the loop throughout the process by encouraging them to report any discomfort or pain. Let's start by targeting the supraspinatus. Begin by palpating along the superior angle of the spine of the scapula. Once you find it, anchor your thumb and apply pressure as you move proximal to distal toward the medial portion of the scapula. Externally rotate the patient's arm while maintaining consistent pressure throughout the movement. After each stroke, allow for a brief reset. Spacing your contact points about ½ inch apart. or spend a few extra repetitions on a particularly stubborn trigger point. It's worth noting that many patients report tenderness in this area, so be mindful of your pressure and patient feedback. This is also a perfect opportunity to educate your patient about the rotator cuff. Many are confused, often thinking it's part of the ball and socket joint itself, so take a moment to explain the structure and function. This flows beautifully into treating the infraspinatus, which lies just inferior to the spine of the scapula. The infraspinatus is a broad, flat muscle that spans the majority of the scapula and plays a critical role in external rotation of the shoulder. While you're working in this area, don't overlook the teres minor. This smaller, more discrete muscle is located along the lateral edge of the scapula just below the infraspinatus. This technique here is identical to what we use for the supraspinatus, so you already know the drill. The only adjustment is to work towards the anterior angle of the scapula, paying close attention to any tightness or trigger points you might encounter along the way. Use steady pressure and remain mindful of your patient's feedback. Before anybody calls me out, yes, I'm fully aware that the teres major isn't technically considered part of the rotator cuff, but honestly, it might as well be. To palpate the teres major with precision, begin just above the lat. Using your thumb, gently sink into the tissue along the lower lateral edge of the scapula. Grasp the anterior angle of the scapula for stability and begin slowly abducting your patient's arm. Bring it to the head of the table. This creates a stretching motion with opposite forces, effectively isolating the muscle. A good rule of thumb is make it disappear into the surrounding tissue. This indicates that you've achieved effective depth without excessive pressure. For those looking to advance the technique, once you reach maximum abduction of the arm, gently extend it slightly. However, if your patient expresses significant discomfort or has limited mobility, avoid this progression to ensure their safety and comfort. Pay attention to your body mechanics throughout this process. Notice how my body naturally sways with the movement, keeping a consistent flow while protecting myself from strain. This rhythm not only makes the technique more fluid, but also allows you to deliver the best pressure efficiently and sustainably. Before we jump into working on the subscapularis, let's take a moment to discuss proper draping. Start by positioning the arm about a 30 to 45 degree angle out to the side. Using the sheet, create a secure seal over the breast tissue by pulling it taut and gathering all the breast with the sheet. This ensures everything is covered appropriately. Once you've created the seal, tuck the sheet in snug to keep it in place. Proper draping not only protects your patient's privacy, but also provides you the access and confidence needed to work effectively. Start by locating the side of the ribcage near the axilla, just above the latissimus dorsi. Once you're there, gently guide your fingers underneath the ribcage while aiming towards the anterior surface of the scapula. It's really important to use the pads of your fingers, not the tips. To confirm you're on the right spot, ask your patient to press their hand into your forearm. As they do this, you'll notice the subscapularis muscle contract and push your fingertips upward. This feedback is a clear indicator you've located this muscle. Once you've made contact with the subscapularis, invite your patient to take a deep breath. On the exhale, gently drive into the muscle with controlled, steady pressure. While maintaining this contact, guide your patient to externally rotate their arm until it approaches the table. Let off the pressure gently as they return their arm to the start position, ensuring you never fully lose contact with the subscap. This avoids the need to relocate the muscle with each stroke and maintains a seamless flow. For an alternative grip, you can use your thumb to engage the subscap. Keep in mind that this grip delivers a more acute pressure, which can feel a bit more intense to your patient, so less is more here. Always check and gauge their comfort level and adjust accordingly. Thank you so much for watching. If you found this helpful, consider subscribing, or at the very least, give that like button load to Peltman for me. Much love and peace out.